Okay, I have 12 o'clock. We'll go ahead and get started. My name is Nicole Newman. I'm at the State WIC office, and I'm pleased to be able to introduce to you today Casey Manser of the Iowa SIDS Foundation. She is the executive director there and is going to talk to us today about some safe sleep recommendations. So Casey, if you're ready, I will turn it over to you.
Great. Yes. Thank you, Nicole. Good afternoon, everybody. Thank you for giving me some of your time today. Some topics might take longer than others, but I think we'll be able to get through everything and have a little time at the end for questions. I want to say before we jump in that our time together here is really for you. So if there's specific questions that you have or things you've encountered in the past where it might be helpful to have some more information or some problem solving ideas, please speak up and let me know. Feel free to put that in the chat and I'll try and keep an eye on that. Or if you feel comfortable, I welcome you to interrupt and you can ask your question during the presentation. I'm hoping today that what we're going to cover here, I'm going to give you some information about the foundation and what we do. We're going to go through safe sleep, the basics of safe sleep, make sure you understand what safe sleep means. And I'm hoping to provide some real life examples because oftentimes when we talk about safe sleep, it sounds easy, right? The ABCs, it's supposed to be easy, but in reality, it's not. And you all probably know that from either having your own children or working with people who have young children. So I'm hoping to provide some real life application for you. We're going to talk a little bit about some data and statistics. And then also I'm going to share some resources with you too at the end. So like I said, at any time, if you have a question or a comment, please feel free to speak up or interrupt me. Right. So before we get too far into things, I do want to tell you a little bit about the foundation and what we do. We are a small nonprofit centrally located here in Iowa. We're in the Urbandale area, but we serve families in all 99 counties in our state. And we also work with a few families in Illinois and South Dakota, just because we are the closest resource to them. So our organization was originally founded by families who had lost an infant to SIDS, and they created our organization initially to provide grief support to other families who were going through similar losses at the time. We developed into a nonprofit and expanded our services to include education. So really we have two main functions, providing that grief support and emotional support to families who've experienced loss, and then providing education to professionals, whether those are medical professionals, professionals like yourselves, caregivers in childcare centers, really anyone who will listen to us talk about safe sleep, we're happy to talk with. And then also supporting medical research into causes of SID and other sleep-related accidental deaths for families. So like I said, we're tiny but mighty. And we are here to support you as a professional within your role too. And we'll talk a little bit more about that at the end when I share with you the resources that we provide. But just know, even after our time today, if down the road a safe sleep question comes up, or if you're wondering how to navigate a conversation with a family that's experiencing some kind of barrier, please know we're here to support you in that. So you can always reach out to us or me directly, and we're happy to talk with you and walk through things with you to support and hopefully give every baby the best chance for safe sleep. So we need to kind of create a foundation here, a baseline, and an understanding of SIDS versus some other terminology of SUID, and I'll define that here in just a minute. But it's likely that all of you are aware of the terminology of SIDS. So I want to talk a little bit more in detail about exactly what it is and what it's not, because there might be some myths or misconceptions there that you have or that others have that you work with. So SIDS, we know, stands for Sudden Infant Death Syndrome. And this is going to be the sudden and unexplained death of an apparently healthy infant who's younger than 1 year of age. This death is going to remain unexplained even after a thorough case investigation. A few things I want to point out when we're talking about SIDS. This is for babies who are younger than 1 year of age. After that, the terminology does change, so just remember that. And this death is unexplained. So there can be no reason found for why this apparently healthy infant died. So when we're talking about a thorough case investigation, that's going to include 3 components. It includes performance of a complete autopsy, which involves internal examination, external examination, blood work, toxicology screens, x-rays, all of that. It also includes examination of the death scene, which is simply where the infant was at the time of death. That could be in their home or in a child care center. And lastly, it includes review of not only the infant's clinical history, but also the mother and their clinical history as well. Within the examination of the death scene, a lot of times this includes reenactment and other aspects as well. And while the investigation is often cited as being very traumatic for families, it's necessary for the medical examiner to try to determine the cause of death. So after they've gone through this process, there can be no reason found for why this baby died. No underlying medical condition that wasn't known. There's no indication of abuse or neglect. There's no, in a case of SIDS, there's no indication of suffocation. This baby just went to sleep and didn't wake up. So it is a diagnosis of exclusion, meaning everything has been said, it's not that, it's not that, it's not that. We don't know what it is. And that's when the categorization of SIDS might come into play. SIDS is also a terminal event, meaning there's no survivors. So there are no near SIDS events. The first and only symptom of SIDS is death. So these are unexplained deaths. And it's important to note that when it comes to the categorization of deaths or the cause of death, that is up to the discretion of the medical examiner. In our state, any child who dies, who's under the age of 2 for an unknown reason, is mandated by law to have an autopsy. And so there is no standardization when it comes to the categorization of these deaths, whether in our state or even nationally. And that is something that the American Academy of Pediatrics is pushing for so that we can have better data and more clear information. So in contrast, there is another term I want to talk about with you, and that is SUID. Maybe you've heard this, but you're not as familiar with it as you are to SIDS. There are some similarities and there are some differences. So I want to make sure I cover that with you because both of these terms are part of our mission statement. And both of these terms, we can help reduce the risk and prevent accidental sleep-related deaths. So SUID is a term that's used to describe any sudden and unexpected death, whether explained or unexplained, including SIDS during infancy. So sometimes things get a little blurry here and people get a little confused, but this graphic can kind of help clear that up a little bit. The main difference between SIDS and SUID is that SIDS, remember, is always unexplained. We don't know why it happens, but SUID deaths can have explained causes. And this image kind of helps clear that up a little bit. So if you think about SUID being a broad umbrella, and it has subcategories. So, and these subcategories have explained or unexplained causes. So SIDS is a subcategory of sudden unexpected infant death that has an unexplained cause. But there are other subcategories of sudden unexpected infant death that have explained causes, such as those accidental sleep-related deaths, overlay, accidental suffocation or strangulation in bed, abuse, other metabolic disorders. So those are categories, subcategories that have explained causes, and SIDS does not have an explained cause. So the terminology has kind of started to fade out from SIDS being used to now that category of SUID being an all-encompassing category being used more often. So it's important that we know that both of these terms exist and we understand their differences. So the question often is, well, why do we focus on these sleep-related infant deaths if SUID can have other categories? And the reason is because of the data and how it breaks down. So the most recent data here is from 2020, and this is national data. We'll talk about Iowa data in just a little bit. But in 2020, there were over 3,000 infant deaths that were classified in the broad umbrella of sudden unexpected infant death. When they break those down, over 1,300 were classified as SIDS, having no known cause. Over 1,000 were unknown, which is another blurry category where sometimes a medical examiner might not be comfortable using the terminology of SIDS because they're not sure. And so they kind of cover their bases by going with the unknown category. And over 900 of them were accidental suffocation or strangulation in bed. The majority of these include unsafe sleep practices. So the point and the reason why we focus on safe sleep is that we have the potential to save lives. If we can provide that education, we can prevent accidental sleep-related deaths and reduce the risk of SIDS. So because SIDS does not have a known cause, we can't 100% prevent it or eliminate it, but we can reduce the risk by following the safe sleep recommendations. So this is why we focus on the safe sleep education. So again, some national trends here for you, just to kind of help you understand. I feel like sometimes some professionals think, well, you know, SIDS was the big thing in the 90s, but does it really even happen anymore? You know, what's really going on? And the truth is, yes, it's still happening. So this graph kind of helps break down some of those sudden unexpected infant deaths by cause. You can see here some different categories. And then the main ones I obviously want to focus on are SIDS and then accidental suffocation and strangulation in bed. So the SIDS trends is illustrated by the blue line, which is the second line up at the top. And you can see in the 90s how significant that was. The Back to Sleep campaign started in the early 90s, 93. And so you can see the significant decline of SIDS rates in the mid to late 90s, which is great. It was kind of at a plateau for a while. And then most recently in 2020, unfortunately, there has been an increase in SIDS rates in our country. The reasoning for that is a little unclear. We're not exactly sure why there was a sudden increase in SIDS related deaths, but the point is there was. So we need to continue that education and make sure we're really talking with families about reducing their baby's risk. And then I also want to point out the accidental suffocation and strangulation in bed. That is the green line you see there. And you can kind of see some similar trends of a slight increase around 2019 and kind of a plateau from there. But accidental suffocation and strangulation in bed is preventable. We can prevent accidents by educating families about safe sleep and helping them follow those recommendations. So this is kind of just gives you a good illustration of current national trends in our country. In contrast, I'm going to talk to you a little bit about Iowa data here in just a moment, but I want to share some more information when it comes to data and the breakdown in population that we see when it comes to sudden infant death syndrome. So I want to make the point to make sure we all understand that SIDS is democratic. It can impact any infant regardless of their race or their ethnicity. So we want to make sure we're educating all families. We do see SIDS happening more often in certain groups of people due to certain risk factors that are more prevalent. And I'll talk about that in just a moment, but understand that it can happen to any baby that you're working with. And remember, like I said, the terminology of SIDS and sudden unexpected infant death, SUID, is for infants 1 year of age and younger. So we kind of see some breakdown when it comes to the occurrence of SIDS based on age in the first 12 months of life. So we know that there is a peak of SIDS rates between 1 to 4 months of age, and that's where we see the majority of SIDS deaths. So 72% is where we're seeing that. And then we see about 18% in the 4 to 6 month age range. So what I want you to know based on that is SIDS can happen at any point in the first year of life. It can happen to babies younger than 1 month and older than 6 months. But this is where we're seeing the majority of those deaths in that 1 to 4 month age range. So if we're working with a family who has a baby in that range, we want to make sure they really understand safe sleep and are implementing it. Ideally, we want that to happen prenatally, right before babies are even born, so that they can start safe sleep immediately and not have to break bad habits later on. But it'd be a good idea to make sure we're touching on those points as baby continues to grow throughout their first year of life. And as I already mentioned, SIDS is democratic, but we do see a higher incidence in certain groups of people. We know that African American infants are at a 2 times greater risk of SIDS than their Caucasian counterparts. And that is because we see higher risks or the higher incidence of certain risk factors for those groups of people. So African American infants are more likely to be placed on their belly or side to sleep by their caregivers. They're more likely to co-sleep or bed share with their caregivers. They're more likely to have generational caregivers in the home, meaning not just mom and dad providing care, but grandma or an aunt. And then we also see other disparities that reflect some failures within our society to support these infants as well. So just know that these babies have an increased risk, but all babies are potentially vulnerable. So now let's look specifically at our state. Unfortunately, this graph you see here is from 2015. It's the most up-to-date data that we have available, which is unfortunate, but it still provides a good picture of where we're sitting. We know that Iowa typically has 96 sudden unexpected infant deaths per 100,000 births in our state. On average, our state has around 36,000 births a year. It's been a little higher most recently, but that's the average number. So if we look at that number and we break it down a little bit, that's roughly 30 infant deaths each year. And so this graph is from the Iowa Child Death Review Team annual report, which breaks down some of those infant deaths by category. The one we're looking at here is the orange with the triangles. This represents the SIDS rate in our state. So you can see a decrease from 2010 on, and then we started to increase again in 2015. So the point with these graphs, the point with this data is that SIDS still happens and it's still real and it exists, and we need to continue to talk about it. It's not a thing of the past. It's not something that just used to happen. It still happens, and it still happens in our state and in our communities. So we need to make sure we're talking with families about safe sleep for their babies. To kind of drive this home a little more, I just want to kind of show you that it's real for our foundation and for the families that go through it. These are real babies of families in our foundation who have died of sudden unexpected infant death or a sleep-related infant death. Unfortunately, these pictures are just a few, not even a handful of the families that we work with. We have over 1,000 families in our database who've lost a baby. And so this is a very real thing, especially for them. So we need to make sure we're talking with families about it. So you kind of probably gathered or know already that SIDS can be kind of this mystery, right? Because we don't know why. There's no test for it. There's nothing that we can do to help us predict which babies may or may not be vulnerable. And when we don't know something about a topic, it's helpful to focus on what we do know. And so there are some things that we do know about SIDS. We know that SIDS is not caused by child abuse or neglect. Remember, these babies go through a complete autopsy and there's no indication of maltreatment. We know that SIDS is not caused by vaccinations. It's not caused by choking or vomiting. It's not contagious, and it is not the same as suffocation or asphyxiation. Those are different things. So I feel like a lot of times when a baby dies, babies aren't supposed to die, right? That's not how it's supposed to happen. And so when it does, people look for a reason or someone to blame or a cause that led to that. And when the report comes back that they don't know why, people aren't always comfortable with that answer and they try to figure out the why. And that's where myths and misconceptions start coming up. So we need to make sure we know what SIDS isn't so that we can talk about that with families. That if they bring up a comment that is a myth or a misconception, we are able to address that to help them understand that that's not the causation of SIDS and they're two separate things. So just know that these myths and misconceptions exist, and they might come up if you're having conversations with family about SIDS. So as I said, every baby is potentially vulnerable of SIDS because we don't know the cause, but there are certain risk factors that increase risk for babies to experience SIDS or other sudden unexpected infant death. And so some of these risk factors are within our control, such as environmental aspects that we're going to talk about when it comes to safe sleep. But some risk factors aren't necessarily something that we can control, but we still need to be educated on them because sometimes families have the power to control them, and we just need to be aware. So we see a higher incidence of SIDS and SUID for babies who are born prematurely and have a low birth weight. So babies born before 37 weeks and weighing less than 5.5 pounds have a higher incidence. Infants who are exposed to alcohol and drug use from mom have a higher risk factor as well. Those babies are also more likely to be born prematurely and have low birth weight. And one that's really significant is in utero and environmental exposure to tobacco or nicotine. Researchers have actually spent a lot of time looking into this factor and have found that it's possible to eliminate a third of SIDS deaths if we completely eliminated smoke exposure for these infants. So that's really significant. We want to make sure that we're educating families about the risks of exposure to smoke and tobacco, not just mom who's pregnant, but also other caregivers or anyone who might be around baby. Young maternal age is also a risk factor for infants, having less than 18 months between births and having multiple births as well. And again, that all kind of relates back to prematurity and low birth weight. So we can't necessarily control these things. We can't control how much a baby weighs when they're born or if they're born prematurely. But we can educate their caregivers about drug use, alcohol use, and prenatal care. So we need to be aware of these factors. So during our time today, we're going to talk about the basics of safe sleep in relation to real life examples. And sometimes it can feel like there's a lot of information. There are details and questions that come up, and I'll try and get through those. But we want families to remember the basics when it comes to safe sleep, and that is alone, back, and crib. So I'm going to dive deeper into each of those, and there is more detail that you should share with families. But if they can just stick to that, they're going to be okay. So alone, back, crib, we want to make sure they're remembering that. And then I want to make a point to say that it's easy to remember ABC, but it's not always easy to implement it, right? Because babies get sick, moms get tired. There's other things that happen that can make it hard. And so we want families to know that as well. We don't want to set them up for failure by saying, just put your baby alone on their back in a crib and you'll be fine. And then they try that and their baby won't sleep or their baby keeps crying. And then they don't feel like they can ask those questions or get that support. And then they revert to unsafe behaviors. So we want to make sure families understand it's easy to remember, but not always easy to implement. And I hope to give you some advice or suggestions on how to make it easier for families in the real world. So the environment that a baby sleeps in and their sleep space, those are factors that can help reduce the risk that we do have control over. I want to make sure we understand when we're talking about reducing the risk, what that actually means. So we'll talk about the ABCs of safe sleep, and that's kind of a baseline for families of where we hope they would be. There are going to be other aspects that they can do to help reduce their baby's risk. And you see that kind of illustrated here on this graphic. To further decrease infants' risk, if they combine the ABCs of safe sleep with breastfeeding or pacifier use or room sharing, they can even decrease the risk more. So that's what we want. And then if they don't follow those recommendations, here's a great example of how certain behaviors can increase an infant's risk of death, a sleep-related death. Bed sharing increases an infant's risk by 400%. So that's really significant and kind of jaw-dropping. And so we want to make sure people understand when we're talking about risk reduction, what that actually means. So now we'll take a second to dive a little deeper into what those recommendations mean and talk a little bit more about the details of each aspect. So we know that A stands for alone. And as I'm going through these, I hope to provide a good example of why we need to go deeper in these conversations and not just say alone back crib and move on. Because alone, there's more to it than just a baby sleeping alone. What does that really mean for families? So we know that babies should sleep alone by themselves, physically by themselves in their own individual sleep space. But they should have no pillows, blankets, bumper pads, but they should also never sleep with an adult. So when we're talking about alone, we mean alone free of objects and alone free of people as well. So we need to make sure people understand what alone really means. So babies should never sleep with a caregiver. They should never sleep with a sibling, even if they're a twin or a triplet. Every baby needs their own individual sleep space. So all that baby needs in their sleep space, whether that's a crib, a pack and play, or a bassinet, all they need is themselves on a mattress that's firm and manufactured for that sleep space and a tight fitting sheet. That's all that they need. There are so many things out there that are advertised or suggested for caregivers to use with their baby, and they're just not necessary and they're not even safe. So we want to make sure people understand that alone means no objects, no pillows, blankets, and no people as well. So to further help reduce the risk when we're talking about babies sleeping alone, we want to try to empower families whenever we can. So whenever we have the opportunity to tell them what they shouldn't do, we need to make sure we're telling them what they could do instead. So giving them something where they can take action. So sharing a room with baby is a great recommended safe alternative to sharing a bed, right? So the AAP recommends that families share a room with their baby, ideally for up to the first year of life, but at least for the first 6 months. And this can help reduce the risk even more than the baseline by 50%. So that's a great way to talk with families about something that they can do instead of just telling them what not to do for baby. So again, we know in reality that families get cute pillows and really beautiful embroidered blankets and those stuffed animals. And so what are they supposed to do with them if they can't put them in their baby sleep space? So let's give them something to do. Let's give them an action item. Let's empower them, right? So talking with families about how they can use those items to decorate their baby's room and not the crib. They can put them on a shelf. They can use them during tummy time to play with baby or for baby to lay on a clean blanket when they're doing tummy time. There are alternatives. They don't have to just sit in baby sleep space. And then also, families often share concerns that if they can't use a blanket with their baby, how will they keep their baby warm and comfortable throughout the night? And we're going to talk a little bit about overheating in a little while, but just to keep baby comfortable, a great alternative is a sleep sack or a wearable blanket. these are pretty common. They're often found in stores and kind of all over nowadays. So we want to make sure that if families are using that they understand and are using it appropriately for their baby. So there are sleep sacks on the market that are weighted. Those are not safe. So we want to make sure families know that, and are dressing their baby in the right size of sleep sack so that it's not too big where it could come up over their face, or it's not too tight to make them uncomfortable. So as we're having those conversations and say, well, you could use a sleep sack or a wearable blanket, and they know what that is, great. Don't just move on. Take the time to go further into detail about what a safe wearable blanket is and what it looks like, so that they can understand. So I feel like whenever I have the opportunity to do a presentation or a training, the common challenge that many professionals bring up is that their clients are bed sharing and they're sleeping with their baby because X, Y, and Z. And so they need some assistance in talking with their clients about that. So this is kind of a helpful graphic that kind of shows you the myths or certain comments that families might make about why they're choosing to co-sleep, and then the facts of their choices. So sometimes caregivers will share, well, I'm sleeping with my baby because I want to keep them safe. And so if that's a comment that's made to you as a professional, taking the time to talk with them about what does that mean? What are you trying to keep them safe from? Could be helpful. But making sure that those caregivers understand that in choosing to bed share, they're actually putting their baby in an unsafe situation. We know that bed sharing increases the risk of suffocation, overlay, entrapment, all different kinds of accidents. So while families often have good intentions because they love their baby, they might not realize that they're actually putting their baby in an unsafe environment. Another big one is families will say, well, I'm breastfeeding my baby, so I have to bed share. We want families to breastfeed. That can help reduce the risk, but it's not necessary. You don't have to bed share to successfully breastfeed a child. And so we need to make sure we figure out what the barriers might be of why they think that, and then help them understand that room sharing is a great alternative to that. So keeping baby close to bed for feedings in the middle of the night, as opposed to in their bed with them, is a great alternative. Excuse me. Data has actually shown that breastfed babies who are less than 3 months, because remember that 1 to 4 months is the highest peak of SIDS. Breastfed babies less than 3 months that do bed share are actually 5 times more likely to die of a sudden unexpected infant death than a breastfed baby that sleeps alone in their own environment. So that's really significant. And we want to make sure that people understand that breastfeeding does not make bed sharing safe. Breastfeeding is a risk reduction for SIDS, but you can't bed share and breastfeed and get the benefit of that risk reduction. We need to make sure people understand that. Another big one that people often bring up is they say that bed sharing helps them bond with their infant. And sometimes there's this guilt factor that comes up for working parents or parents that aren't able to spend a lot of time with their baby, and they feel like they want to share a bed with their baby to keep them close and cuddle them so that they know their baby knows they love them. And I think it's important to validate parents' feelings of wanting to connect with their baby and show their baby love. But the truth is that that best bonding time is going to happen when baby is awake, not when they're sleeping. And so I think talking with families about quality over quantity, so helping caregivers understand how impactful making eye contact with their baby after a diaper change can be, that's going to help bond more than sleeping with baby. So helping them kind of work through that challenge of wanting to bond with their baby, but feeling like they don't have the time. And then another one that's in that top 3, I would say, of a myth or misconception or just a general comment about bed sharing is oftentimes people say, well, I slept with my parents as a baby and I turned out fine, or my sister slept with her babies and they're all okay, my friend, insert person here. But this is just an example of survivorship bias. Surviving something that's dangerous doesn't make it any less so. So if somebody gets in a car accident and they weren't wearing their seatbelt and they survived, we don't go around telling people we don't need to wear seatbelts anymore because this person survived and it's okay. That's not how it works. So kind of taking some time to explain that could be helpful. This is often a comment that comes up with generational caregivers. So maybe grandma who's providing care might say, well, I slept with you, so I'm going to sleep with your grandchild or my grandchild. So we need to talk about how now we know more and we can do better with the information that we have now. So on to the next risk reduction aspect. B is for back or the sleep position that caregivers are putting baby in for sleep. So we know that babies should always be placed to sleep flat on their back on a firm surface for every sleep, naps, and nighttime. Never on their side, never on their belly. So we want to make sure that families understand what back actually means. Because sometimes I'll have people say, well, my infant's in their swing, they're on their back, that's fine, right? And the answer is no, actually, that's not okay. In a swing or in a car seat or a positioner like that, if you think about it, baby might be technically on their back, but they're not on a firm, flat surface. If you can picture a baby in that environment, their chins are to their chest, their shoulders are tucked, and so they're not in a flat position. So we want to make sure people understand that flat and firm on the back is the safest place for baby. And I see a question in the chat about breastfeeding and a protocol about bed sharing. And I'm not sure if maybe that's a question that that Nicole, maybe you could answer if WIC has a stance on breastfeeding and bed sharing. That might be a follow-up later, so we might need to come back to that. But so that is the kind of summary of what that.
Oh, sorry,
Yeah.
Casey, I'll just say, yeah, we will, Sarah, take that comment and follow up on it, but share information as well.
Yes, thank you. And I do want to say that there are trying to figure out how to say this nicely. There are some organizations out there that say that you can breastfeed and bed share safely, but it's not research based or scientific based. And so that's unfortunate. And we do need to realize as professionals that there's misinformation out there that families might come across. And so we need to be equipped to provide them with the education that is research and evidence-based. And that's what you're learning here today. So just be aware of that when you're working with families. You can find any answer you want on the internet. So the internet is helpful, but it can be a scary place at the same time. So a common concern that families will bring up is that they're worried that if they put their baby on their back, the baby's going to choke during sleep. And so luckily, because we understand anatomy and how the body works, we just know that that's not the case. And in fact, back sleeping reduces the risk of a choking event for infants. So in the back position, you can see in this image here that the trachea is on top of the esophagus. Our body has protective mechanisms that just exist biologically that protect our airway. And then in the back position, we also have gravity that helps prevent aspiration into the trachea. So if something were refluxed from the stomach and it's coming up the esophagus, those protective mechanisms would exist to protect our airway, and then gravity would help push that back down. But in contrast, when a baby is in the tummy position, we no longer have gravity to help. So if something is then refluxed or regurgitated, instead of being pushed back down, it can kind of just pull at the opening of the trachea. which makes it actually easier for an infant to aspirate. So back sleeping is even flat. Back sleeping is even the recommendation for infants who have reflux from the AAP. So a diagnosis of reflux is not a justification to place an infant on their side, on their belly, or elevate them. And if a physician has said that to a family, that would be kind of concerning. So just keep that in mind. And then lastly, we've covered A, B, and C. Let's talk a little, or excuse me, A and B. Let's talk a little bit about C and what that means specifically. Excuse me. So C is for crib, because crib starts with C, and that sounds really great. But what we're meaning here is the sleep environment that baby's in. So this could be a crib, but it could also be a pack and play. It could be a bassinet. Any environment that was manufactured for sleep and is safety approved. So we want to make sure families understand that they're not limited to a crib if they don't have the space for it or can't afford it. A pack and play is a safe option for them as well. And even bedside bassinets that are safety approved can be an option too. So we want to make sure people understand that. Regardless of what they choose, whether it's a crib, pack and play, or a bassinet, we want to make sure it's safety approved. And we want to make sure that families are reading and implementing the user manual recommendations. That's super important when it comes to bassinets, especially because oftentimes those are rated for a certain weight. And once baby reaches that weight or a certain milestone, such as sitting up, they need to be moved into a different surface or environment. Same when it comes to like lowering the crib mattress. We want to make sure people understand when they're supposed to do that so that they can avoid other accidents as well. And so whatever environment that they're choosing for sleep, we want to make sure that they keep baby alone in that environment. So just a firm mattress with a tight fitting sheet. They don't need to add anything to it or change it in any way. Especially pack and plays, this happens a lot. Families will say, well, I got this pack and play for a safe sleep space for my baby, but it's really hard. The mattress, quote unquote, is really hard. It feels like a piece of wood. I want my baby to be comfortable, so I'm going to add something to it. That's not safe. We don't want people adding things to cushion the environment baby's sleeping on. Firm is what baby needs. So when it comes to comfort for infants, that softness does not equate to safety. And it's not what babies need. And so we want families to know that, and to also know that when it comes to if they're changing their babies or adding something to that environment, then they're not following the user manual recommendations. And so then it's not a safe sleep space anymore. So make sure families aren't adding to that, and make sure that they know that softness does not equate to that safety. When we're talking about sleeping in these environments and following the safe sleep recommendations, these are learned behaviors. Safe sleep is a learned behavior. Sleep in general is a learned behavior. Babies aren't born knowing how to sleep. And so we need to set them up for success by following these safety recommendations as soon as they're born, so that we're not trying to break bad habits later on. So this is just a helpful image that shows you some common environments that are used for sleep for babies that are not safe. So babies should not be sleeping in an adult bed. They should never be sleeping on a couch or a recliner. Whether they're with or without a caregiver, they should never be on those surfaces. Swings, car seats, those kinds of things are not safe for sleep. And so I want to make sure that people understand that just because something is sold and available does not make it safe. The regulations in our country lag behind. And so oftentimes things aren't recalled or change the regulation of until after an accident happens. And the perfect example of that is the Fisher-Price Rock and Play. You see that pictured at the bottom. It's the pink little swing thing. But these were created and manufactured and advertised to families to be a sleep space for their babies. They're not flat. It's an inclined surface. They're not firm. They're not safe. Oops, sorry. I didn't mean to advance my slide there. So these weren't recalled or taken off the market until many babies died, and they realized that these aren't safe for that purpose. And so families need to know that just because they can get it at Target or Walmart doesn't mean they should use it for their baby. In the same breath, I also want to make a point to say that when things are used for their manufactured purpose, they're okay and they are safe. And the example of that is a car seat, right? When they use car seats for their manufactured purpose, which are to keep babies safe in a moving vehicle, yes, please, we want families to do that. In fact, it's a law that they have to be in a car seat. But when they start using things for purposes that they're not manufactured for, like sleep in a car seat, that they're no longer safe. So swings and positioners are great to put baby in if a caregiver needs to do something, if they need to make some dinner or whatever, that's perfectly fine. But if a baby falls asleep in those things, they need to be taken out and put in a safe sleep surface. So there are no positioners or anything out there that makes co-sleeping safe. Those don't exist. So we want to make sure people understand that when it comes to sleep, it's old school and it's easy. It's a crib, a pack and play, or a bassinet. So some other common challenges that come up when we're trying to apply safe sleep to the real world is sometimes caregivers share, well, my baby doesn't like the crib. They cry when I put them in the crib. They don't sleep. I don't know what to do. And so when you're navigating those conversations or concerns with families, it's helpful to remind them that sleep is a learned behavior and it's going to be hard, but if they stick to it, their baby's safety is worth it, right? And so kind of problem solve and give them help and advice for what they can do while they're trying to help their baby get used to that sleep environment. So maybe that's talking about the startle reflex, when you're trying to put a baby down and all of a sudden they flail their arms and wake themselves up. So how can you work on that? Making sure baby's physical needs are met and making sure we're using or exploring any other environmental supports that are safe, like white noise, a dark room. What are some other ways we can support a baby when they're sleeping in that safe environment? Another one is that families will say, well, I don't have space in the room with me to put my baby. There's no room for a crib. It's just not going to happen. And so talking with them about problem solving. Is there a different way you could rearrange your room for a while baby's in there with you? Could you use a pack and play that's smaller than a crib or a mini crib, which is even smaller? So just kind of talking through those things so that you can help families follow the recommendations and they can be successful because they're equipped to do it in their own space in their family. And then another common one is families will say, well, I can't afford an additional sleep space for my baby, whether that be a crib, pack and play, or a bassinet. And so when it comes to this, hopefully you're aware, but if not, there are actually very many support services out there that provide free, safe sleep surfaces for babies to sleep, including the foundation. So if that's ever a barrier for a family you're working with, please know that there's resources out there that can get them connected with safe sleep spaces for completely free. So if that comes up, feel free to reach out to the foundation or to me. Just a real quick question I'm going to address here in the chat was that there is a common practice, or they've been hearing of a practice where moms will sleep on the mattress on their floor with their baby. Moms having their baby sleep on a mattress on the floor. Okay, so maybe baby sleeping on a mattress or mom and baby are sleeping on a mattress. Either way, that is not safe. Okay, so if they're sleeping on an adult mattress, that's not safe. If they're sleeping with a caregiver on a mattress on the floor, that's not safe. If they're sleeping on a baby mattress, like that's made for a crib, but it's not actually in a crib, that's not safe. So I guess a real easy way to answer this question is when it comes to how does it fit into safe sleep environment guidelines, it doesn't meet safe sleep recommendations. That would not be a safe sleep space for that baby. They need to be in a crib, a pack and play, or a bassinet. So there'll be like trends out there or practices that come and go. And so we just always need to look at those and evaluate them based on the evidence-based recommendations to help decide if that's safe. So a mattress on the floor, especially if that's an adult mattress, it's not manufactured for an infant. That means it's not firm. So that would be worrisome. And then if an infant were to roll off of that onto the floor, they could injure themselves. They could become wedged between the mattress and the wall if it's on the floor, and it could suffocate. So lots of concerns there. So always just go back to what you know is safe, compare that, and make a decision based on that information. A few things I just want to cover quickly that come up to provide additional ways to help reduce the risk. We want to make sure that when infants are sleeping, we're never covering their heads, and we're keeping rooms that are at the temperature set where it's comfortable for a lightly clothed adult. So I feel like hats is a big one. Oftentimes because families see nurses put a hat on their baby after birth, but once baby's discharged from the hospital and they're healthy and they can regulate their own body temperature, they do not need, and it is not safe to wear a hat during sleep, especially when they're indoors. So we want to make sure families understand that. They should monitor their baby just to make sure they're not overheating. Look for those signs of flushed cheeks or rapid breathing that would indicate that the temperature in the room needs to be changed, or a layer of clothing needs to come off, or something like that. Other recommendations include supporting breastfeeding, because we know that is an additional mechanism that reduces the risk. We want to make sure that families understand pacifier use can also help reduce the risk for babies. The mechanism for that is still a little unclear, but they have shown that it reduces the risk. We want to make sure if families are choosing that they're using pacifiers that are safe. So if they're using them during sleep, there should be no animals attached to them, no strings, nothing like that could pose some accidents potentially. And then a hot topic is often swaddling. We need to understand that there's no evidence that swaddling reduces SIDS. And in fact, it can increase an accidental death if a swaddled infant is rolled or placed into a belly position. So if swaddling is being done after those first few weeks of life, we need to make sure families know when they should stop swaddling and how to stop swaddling. So when an infant exhibits any signs of attempting to roll, they should no longer be swaddled immediately at that time. So attempting to roll could involve moving their legs up and sort of to the side, trying to move their shoulders, anything like that, then they should no longer be swaddled. Families need to realize that infants might attempt to roll for the first time during sleep. And so they need to really monitor their infant if they're swaddling to check and see when they should no longer continue that practice. If they're proactive, they could ease the transition and start slowly transitioning baby out of a swaddle. But once they show any signs, it needs to be stopped completely. So make sure we're having those conversations if a caregiver is swaddling. And I know for me with my own children, that was a habit that was hard to break. So starting earlier can be better sometimes. So we want to make sure that we are aware of all the AAP recommendations so that we can share those with families when it comes to risk reduction. So I have a few more listed there. But the big one I want to talk about is avoiding commercial devices or monitors that are marketed to reduce the risk of SIDS. Again, just because it's sold doesn't mean it's safe or needs to be used with babies. There's no monitor out there, wearable or not, that can alert a caregiver of a SIDS event. The AAP does not recommend wearable monitors or cardiorespiratory monitors unless prescribed by a physician due to a medical reason. So these are often expensive things that just aren't necessary. So families need to know that they don't need these things and they're not necessarily safe for their baby. So kind of in summary of those recommendations when it comes to real life application, just remember it's a learned behavior and it can be hard. And we need to tell people that it's hard, their baby's always going to be worth it. And you can help support them, hopefully. And these safe sleep recommendations apply to any time an infant sleeps, whether that's a 5-minute nap or through the night. So anytime baby's sleeping, they always should follow those recommendations. And it's a parent's responsibility to ensure that anyone that's providing care for their baby knows the recommendations for safe sleep and follows them. That includes grandparents or childcare providers. So we want to make sure we're empowering parents to ask those questions and educate others as well. So bottom line, when we're talking about safe sleep, it's our professional responsibility to educate others about this. And if we have to point out unsafe sleep behaviors, we need to do it. It can feel uncomfortable or maybe awkward, but we are potentially saving an infant's life here. So we need to be willing to have these difficult conversations. We can approach them with empathy and really have good conversations. We're not trying to shame people for the choices that they made or if they're unaware of recommendations. But we do need to bring it up and be willing to ask those questions and encourage families to dialogue with us. So my 2 cents or my advice for this is when you're having safe sleep conversations, make sure you have your poker face on because sometimes people will say something about how they're sleeping with their infant or how they're feeding their infant or whatever, and it's very worrisome. But we want to try and stay neutral so that we can educate more effectively, because if we make them feel judged, the education is just not going to be effective. So as we wrap up our time, I want to cover 2 more things here. I'm going to wrap up this and then talk about the support we have for you as a professional in educating others. But sometimes we will provide the education many times through different ways, and we just don't get anywhere. And families are still choosing to follow unsafe or to engage in unsafe sleep practices. One day, I hope that when it comes to safe sleep, it turns just like it is with car seats, that we would never let someone drive away with their baby not restrained in a car seat. But that's not how it is at this time. So there might be an instance where you've worked really hard to educate, to build rapport with a family, to meet them where they are, but still, despite all the education that you've given, they're choosing to sleep with their baby or practice an unsafe behavior. If that happens, here's our advice for you. Express appreciation to that family for listening to you and make sure that they simply understand that your goal is just to make sure they have all the information when it comes to caring for their child, and just kind of leave it there. You can always come back to that topic. You can ask follow-up questions, but just realize that we can't make people do anything. And sometimes that can be really frustrating and unfortunate, but it's the truth. And so making a statement such as suggested here, that if they're talking specifically about bed sharing, a great recommendation is to say, well, I can't tell you how to sleep safely with your baby because there is no safe way. But I want to encourage you to reduce the risk of suffocation by remembering many of the other points we talked about, such as how baby's dressed, if there's pillows, blankets, those kinds of things in the environment. So we're never abandoning those evidence-based recommendations, but sometimes we just have to end that conversation for a period of time because families have heard it all and are still making a different choice. So just know that that happens. And maybe one day it won't, but until that time, we can still meet families where they are and support them to the best of our ability. So I just want to make you all aware of the various resources we have to support you in this education endeavor. We have different tangible items that are available to you for free in any quantity. And those are pictured here, some of them anyway. We have our safe sleep brochures, posters, and our new one is our safe infant sleep field guide, which hopefully all of you should have gotten or have access to within your local agencies. They were sent out to all the WIC agencies. So maybe you've seen it. If not, ask someone in your area. But These field guides provide great tips and suggestions for directing conversations when it comes to safe sleep. There's conversation starters, there's suggestions for how to deal with challenges or situations you might encounter. So we're really excited about this guide and hope it's really helpful to you. But do know there's other resources out there for you as well, and we're happy to get those to you. You can order them on our website, or you can email me as well, and we'll get you connected. At this time, all of our resources are in English, but if you are looking for other languages, we have connections. So still reach out to us and we'll point you in the right direction. So hopefully, I hope most of this information was review for you, but if not, maybe you learned something new. And I hope you kind of feel supported and equipped to talk with families about safe sleep. If something comes up in the future and you'd like to have some suggestions or advice on how to deal with those, please reach out to us. You can follow us on social media. We're here to help and support you in any way we can. So thank you for spending your lunch hour with me. And if there's any questions, feel free to put them in the chat or follow up with me at a later time. But I appreciate it, everybody.
Thank you so much, Casey. If you have any questions for Casey, like she said, put them in the chat, or she's provided her email address here. You can send them to her, send them to us. But we appreciate all the information today and hope you have a good rest of your day, everybody.
Thanks, everyone.
Thank you.